Yeah, very well. I can hear you very well,
At the
Shaq.
moment we see you.
I'm hearing you.
Okay. So I've got I've got Oliver, Mark, Gregor, and Gianfranco with me, and quite a full room. So please go ahead.
Yeah, thank you, Shaq.
With your case presentation.
One of my colleague now will present the patient.
Good afternoon. Greetings from
It's
Maras
a
Medical.
minor criticism, but Shiva.
It's a black font
Shiva.
on a dark background, not seen well.
Exactly.
Sorry about
Exactly,
it. Sorry,
yeah.
very
But
sorry.
So you'll have to speak clearly and loud.
Greetings. Good afternoon, everyone.
Okay, go ahead.
Patient, Miss S. presented with class 2 dyspnea and exertion and progressive worsening cyanosis for the last 6 months. She was diagnosed as a case of cytosolitis dextrocardia, truncus arteriosus in the neonatal period and underwent truncus arteriosus repair with RV2PA conduit in 2006 at the age of 8 months. She subsequently developed conduit stenosis with peripheral branch PA stenosis and underwent RV2PA conduit replacement with a 16 mm St. Jude biological conduit with enlargement of branch PAs in June 2009. During the follow-up in 2015, diagnosed was severe conduit stenosis with suprasystemic RV pressures and was advised surgical repair, but was not done at that time. In June 2017, she was evaluated in Korea, and echo had showed a grade 2 TR with P gradient of 182 mm mercury with a 5 mm ASD with enlarged aortic root to grade 2 AR. She underwent the cardiac cath was done at that time, which was showing a gradient of 165 mm mercury between the RV and PA with suprasystemic RV pressures. Subsequently, she underwent RV to PA conduit change with Contegra 18 mm, PA rerouting under the aorta, LPA os angioplasty with bovine pericardium, RVOT muscle dissection, ascending aorta replacement with a gel weave 24 mm, and truncal valve repair, compsoplasty on July 2017. During the post-op period, CT was done, which showed bilateral branch PA hyperplasia with stenosis. Proximal RPA was measuring 3.9 into 3.4 mm. Proximal LPA measured 4.4 into 2.2 mm. Pre-discharge echocardiography showed a grade 2 TR with a gradient of 133 mm of mercury. On examination, weight is 22.9 kg. Pulse rate is 84 minutes per minute regular. C is saturating at 55% in room air. On CVS examination, JVP is elevated 6 cm above the clavicle. Apex in the right fifth intercostal space in anterior-axillary line. Right pasternal heave. 3/6 ejection systolic murmur in the right upper sternal body. Hepatomegaly is present. X-ray is showing situs solitus dextrocardia, cardiomegaly with CTR ratio of 70% with the left hemidiaphragm elevated as compared to the right hemidiaphragm due to left diaphragm palsy. ECG is showing sinus rhythm, QRS axis of plus 240 with complete right bundle branch block with QRS duration of 140 milliseconds. This is a apical 4-chamber view showing a severe TR with a predicted RVSP of 120 millimeters of mercury. This is a apical 4-chamber view showing a 7 mm oscillosecond ASD shunting right to left. This is a parasternal view showing the anteroposterior relation of the RPA and LPA with severe bilateral peripheral branch stenosis with gradient of 95 mm of mercury across both RPA and LPA. This is a subcostal view showing the left diaphragm palsy. So final diagnosis was severe bilateral peripheral pulmonary stenosis with 7 mm PFO shunting right to left with moderate RV dysfunction with left diaphragm palsy. CT pulmonary angiography was done, which showing a proximal RPA measured 2.7 millimeters of mercury, 2.7 millimeters. Distal LPA measures 8.9 millimeters. Distal RPA measures 8.5 millimeters and proximal RPA measures 3.5 millimeters. This is the sagittal cut, which is showing the anteroposterior relation of the RPA and LPA. So final diagnosis was cytosolitis dextrocardia, status post truncus arteriosus repair in 2006, status post redo RV to PA conduit replacement bilateral PA blast in 2009, status post redo RV to PA conduit change with 18 mm Contegra into July 2017, severe bilateral peripheral pulmonary artery stenosis, hypertrophied RV, 7 mm PFO shunting right to left, moderate RV dysfunctions, left diaphragm palsy. Plan is bilateral pulmonary artery stent angioplasty.
Then, what is the
complex one?
Shaq, can you hear me?
Okay, Shiva.
Yeah.
Yes, we can.
Shaq, can you hear me?
Yes, we can,
Okay.
and we can see you.
Okay. Shaq, the child's hemodynamics, when we did go to the first frame, when the hemodynamics today are the right atrial mean pressure was 18 millimeters of mercury, 18, quite severely elevated right atrial pressures. RV was systemic, and we measured the first picture. Yeah, run it. So this was basically, you would have heard that this is a patient who is having some sort of a dextro position. So the heart was more on the right side, and also she has a left diaphragm palsy. We have intubated, and so the diaphragm is moving now, but the left diaphragm was at a higher level. This was a picture that we just took to find out whether we are well within the left pulmonary artery, and here the pressure was 25 against an RV pressure of around 105. Next picture. So then we Then we crossed with another venous sheath. Now we have two venous sheaths, right femoral vein going into the right pulmonary artery and left femoral vein going into the left pulmonary artery. Next. I think that is Shaq's rule I used to hear. So this is the angiogram from the distal end of the Contegra conduit. It's an 18 millimeter Contegra conduit. You can appreciate here that there is a crossed pulmonary artery. There is a malposed pulmonary artery. The right is arising from the left end of the conduit and left is arising from the right end of the conduit. Actually, this crossed pulmonary artery in the setting of truncus arteriosus is well known to cause this sort of PA narrowing. Then next picture. So this was this is some steep caudal that we gave. We were just trying to find out which particular view will open out the PA to the maximum. We still have not deciphered it well for the right. Next picture. So this was the total opening out of the left pulmonary artery. So here this was a linear narrowing, especially involving the ostium. Show the measurement here. Go to photo. Go to photo. The photo on the top.
And after the measurement,
yeah. So this.
Shiva, after you've shown the measurements, if you could just stop there and let me
sure
ask a few questions.
Sure, sure. So this was measurements were around up to the branching point. It was something like around 35. At the hilum, it was 6.8. The ostium was just around 2. Next. Yeah, next picture. Okay, next picture. Okay, enough. Yeah, Shaq.
Yeah, what about the measurements of the right pulmonary artery? If you stop there, but right pulmonary artery measurement.
Okay, right. Can you go to the right. Next right where we measured? Show the next. Show the no the right one. The right, not that one. Next one. Correct. Shaq, this was the best that we could get for the right.
Measurements of that.
Yeah, just can you?
Yeah, that's pretty good.
Is there
one
any
of the
better
measurements
picture?
near the that upper lobe branch,
Next.
and then more proximal?
We measured one here. No, just go back to that. No, not this one. The right. Okay, can you go and measure this? Shaq, we'll just take a measurement. We eyeballed it as 3 centimeters.
Whilst you're doing that, yeah, whilst you're doing that, I've got some experts who are so well-known experts in branch pulmonary artery stenting. So I'm going to pass through the panel and see what they suggest. So Oliver up first.
3.
Yeah, thanks, Jacques. Hello. So, yeah, I mean, this girl has had a fairly rough history.
10:30.
I think
10:30. Oliver, I am not able to hear you well.
Try again.
Yeah, sorry, yeah. No, I think this is certainly a good indication to do something. The problem is you will have to use 2 overlapping stents. And yes, two-catheter technique. I don't think there's anything to be done with a tandem stent here because you don't have enough distal. And I think, again, it demonstrates our difficulty to profile some of these lesions with conventional angiography.
So in a nutshell, which stent and which diameter?
I probably would go for Cook formula stents, 30 or 40 millimeter length and at least 8 millimeter.
8, because that measurement on the RPA is 13.
That
I think,
measurement is wrong.
that's-
Tell them to use the marker on
distal
the
there,
straight
so
segment.
probably 10 for the RPA and at least 8 for the LPA.
Okay. Right, Mark? Have you got a microphone? Yeah.
Just a few comments. I think this would have been an ideal candidate for perioperative stent implantation after the previous operation.
Yeah.
Because the combination, I think it was a Venpro graft.
I think it was.
Typically, that will give Contegra. Typically, that will give enormous pressure waves on the thing. It will jerk under anastomosis with the pulmonary artery. That's typically what
Okay,
you get.
but they didn't do it intraoperatively, so now what?
Mark, I was not able to hear you, Mark.
Just a situation.
Can you hear him now if Mark says something?
Yeah. Second comment, with a suprasystemic right ventricle, things should go fast. So, because this patient is in bad shape,
Yeah.
and some of the pictures he showed, I hardly saw blood going forward.
Yeah.
So, we have to realize that you keep tricuspid valve open, things like that. And I think one of the most important things that he said was that the patient has a PFO, so at least he can decompress
Yeah.
the right atrium.
So what stent and what diameter and what length?
I would do first still balloon interrogation if I have the time. I think that the distal, that the shortening will be very short. And I just would...
So what diameter stent and what type of stent?
Cook formula stents, but not
The
as
previous
long. I
cycle,
think
the
with
previous.
shorter stents, probably you can get away much better.
Okay, and diameter?
That's what my balloon interrogation
Okay.
will tell me.
All right, so pass it, Gregor, very quickly before we
Very
push
quick.
Siva.
Very quick, I would like to go back to the CT and look for the 3D, which is not practical now. Second stent, I would start with the right, do an eye stenting, put an EV3 36 millimeter length mega LD on the balloon 12 power flex, and then second, penetrate the strut, because I would like to start the RPA stent in the distal contegra to grab the distal PA problem, and then
Diameter மாத்திரம் கொடுத்தா போதும்னு சொல்லுங்களேன்.
strut opening and place second EV3 or a Cook and put them to the left. Again,
Okay.
it's 36 mega.
Okay, Gianfranco, very quickly,
Very
because we've
quick
got to push
question.
him.
I would go for value stance 8 by 26 on the left and 10 by 26 on the right.
Okay. All right, Shiva, so plenty of suggestions there with some variation. So what have you done?
Yeah, so I agree with Dr. Mark that this patient has been operated 3 times, and so a balloon interrogation to study the compliance characteristics of that vessel is important. So we did that. Now this is the right measurements. The right measurements are somewhere around 8.5 millimeter at the hilum, and the length was somewhere near 3 centimeters. Now I will come and show the balloon. Go to the previous picture. Prabhu? Show the previous. Okay, this is the balloon. So this is a 8 Boston Scientific Mustang balloon going up to 18 atmospheres, and it is able to stretch it well. So this is an 8 millimeter balloon. Next. So then we using that balloon, I advanced the sheath deep inside. Now this is the right was already the sheath was inside the PA. Next picture. So we were trying to find out how we can open out the right. So we advanced the marker pigtail, while the mediastinal portion of the PA has opened up. The ostial PA is not opened up. There it is getting foreshortened. Next. So then I decided to go caudal. However, here also there is a lot of foreshortening. Anyhow, with whatever information that we have, already based on the CT, we had thought of putting in anywhere between 35 to 40 millimeter will be the length of the lesion, and we thought at least a 10 millimeter, the patient should get a 10 millimeter stent right now. So I agree with Dr. Oliver that probably I will take a 10 into 30 on both the sides, because on the left we have a very clear measurement of 3 centimeters. Right, it looks like it may be 3 or maybe a little longer. However, I'll stent the ostium, and hopefully the hilar portion or the pre-hilar portion of the PA will still be flexible, because that is not a place which the surgeon has touched so far, and so probably that area might expand. So I was intending to take a 10 into
bearing in
3.
mind Mark's comments about suprasystemic pressure, are you planning to do one branch first and then the other, or both together simultaneously?
Now the issue about one branch first and then the second one, if I get a hyperperfusion injury suddenly, one thing I will tell you, this patient has a PFO which was shunting completely right to left, and the child's resting saturation in room air in the clinic was just between 40 to 45%. And then we ventilated the child, and on 100% FiO2, on 70% FiO2 the saturations were 70%, and now on 100% FiO2 the saturation is 82%. It's quite a remarkable right to left shunt across the PFO. So if suppose the girl gets into a hyperperfusion lung injury, then the hypoxia will be more profound. So I'm going to stent simultaneously. The problem about simultaneous stenting will be there will be a hemodynamic compromise, but the PFO will probably maintain the systemic circulation. Next picture.
Okay, yeah. So let's keep you going. So what's your next?
So this is the right side
One
balloon.
question or 2 questions?
Next.
Wait. One question.
Yeah.
Siva?
Yeah.
Mark and I discussed. Is this a bifurcation with the eye splitting, or is it just like 2 branches which are connected separately to the contegra?
Separately.
2 tubes or 1 eyepiece? What is it?
It is 2. It's like a double barrel. It's double barrel. It's I'll show you one picture. The right.
So
show the
keep
first picture.
Keep going.
There was one that was separating the ostium. Can you show that? Next picture. Show.
Previous.
No, previous. Next picture. Next. Next. No. Here also it's not showing up. Correct. You see here in this picture, Shaq, the left is superior and the right is inferior. It's like a 2 barrel. So I will use this particular image to ensure that both the stents project into the proximal contegra. Show the last fluoro now. Okay, this is where we are currently.
What French sheets are there?
These are 2 7 French Cook flexor sheath, both of which can deliver a 10 into 30 Cook formula. Now I heard Dr. Gianfranco mentioning about Edward Valio stent. Our experience with Valio has been not very good because it crushes. Its radial strength was not as good as the formula, and so we had some serious stent fractures on the pulmonary artery in couple of patients where we implanted. So we tend to prefer a formula more than a Valio. However, I know that the Italy has got a lot of experience with Valio. So now I am
So are you putting in both 10 millimeter or
10 millimeter into 30? I'm just positioning it. I'm not going to deploy. I will be going with the other one also inside. Can you get another 1030? Yeah. This child had two.
Hemodynamics are okay. Is the ECG okay as well?
Yeah. ECG is showing some lot of prominent ventricular hypertrophy with some repolarization changes, especially on the second lead. You can find a lot of ST elevation. But I suppose that is due to marked RVH.
Yeah.
One important point to point out is also that with conventional angiography, certainly you always underestimate the length of the leaf.
Yeah.
Yeah.
Because you can never fully profile it.
Yeah.
Which is why CT and or MRI beforehand would be enormous benefit. So let's keep you moving because we don't want to waste time with this.
You see,
hemodynamics.
you see now this is the place where the two are bifurcating, and so I am starting off with this position. I'm going to peel back the sheath, get two indiflators across both. I'm going to peel back the sheath one by one. I'm starting off with the left. This patient actually had 3 surgeries, and so during the second surgery,
if there are any questions, just put your hand up and I'll try and...
During the second surgery, there was a right femoral venous cut down, and during the last surgery, there was a left femoral venous cut down. So there was a lot of groin scar, and I had a lot of difficulty in...
Makes it easy for you.
Yeah, well, like a lot of pressure was needed to push my sheaths across inside.
Contrast.
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 Contrast on table. So I'm just making one check here. I will peel back the other one also and then fine adjust the two, because this is the place where the two are bifurcating. No.
I would say that the other view where it could show that both vessels came apart from the contegra is probably the view I would choose to.
I'm coming there. I'm coming there, Mark. I'm just trying.
Okay.
Okay. Show that AP-like projection, which was showing the two separate.
Parallel equation.
Yeah. Was this picture? Can you show me the angio here? Next.
Next. Next.
Go slowly. Next. Next. Yeah.
This one.
Yeah. Yeah. So what is this view? LAO 43 caudal 2. Yeah. LAO 43. Yeah. That was the view for the LPA. So I will inject now for the left. I'll come out. Actually, the LPS marker was the two small metal clips, and we decided that we will pull back the stent. There's a lot of groin tightness.
It looks as if you need to be proximal to those a little bit.
Yeah. I'm just at that place. Make it magnified. Yeah. The left possibly is okay. Now I'm going to peel back the right.
Oliver, any thoughts looking at those angios? Or that angio?
Yeah, no, I mean, it's near perfect. I normally try to get one strut or one row
More
of
proximal.
cells proximal.
Yeah.
I would never ever use an indiflator.
Come to some other view where the RPA ostium is exposed. Go to steep caudal.
Here also, I'm sure that the result is going to be perfect.
Can you rotate rightward and leftward and see where the two are separating? No. Come the other side.
Only the first centimeter that is narrow.
Come the other, little bit more. Yeah, you can appreciate here the crossing of the pulmonary arteries very clearly.
So you would have used shorter stents. Yeah. Okay.
Who was that using shorter stent?
Mark was suggesting that he would have used shorter stents.
Yeah.
I think I would have been happy with this length as well.
Because the proximal 2 centimeters, the surgeon has done 3 times pulmonary artery plasties. They have used bovine pericardium to augment the proximal portions of the PA. See, I am not getting the RPA ostium very clear. The left is okay. Go back to that same left view.
So do you think Do you think the RPA one needs to come back about 3 or 4 millimeters?
I'm not sure, Shaq. Basically, the two pulmonary
not that
arteries on the
beautiful, huh?
original echocardiogram
Yeah.
and the CT were arising together. It was not like there was a offsetting between the two pulmonary arteries. The only thing now I am not getting
Yeah.
the profile of the.
There's actually no
Can you come to RAO?
there's actually no harm in having a little bit more of the stent in the MPA or in the conduit, is there?
Yeah. Here it is slightly. Yeah. Go cranial. More cranial.
Yeah, flare it afterwards.
Okay. If possible, take out all those wires. We are going to bizarre views now.
I would also come a bit more proximal because I think you have to have an area where the two stents overlap. If they just touch one another, they may slip over, then you fail one of the branches.
It's not getting visible at all. So see,
That doesn't
the
help.
problem is the contegra is balloon.
Useless projection.
Can you go back to the same where it was two, where one on the top and one on the bottom? I think that LAO 45 again.
I think your two projections were that caudal one and that left lateral one, and I think you have to make decisions just on those two views rather than all these others.
The ECG has gone up.
Could you try just a straight RAO?
Yeah, this is a straight LAO. I'll give one injection here.
Could you try to go in a RAO?
Left anterior oblique. Go a little. Okay.
Right anterior oblique, just to profile the.
Let's do this and then.
Yeah, I'm coming there. Left is looking okay. Actually, on the CT scan and on the echocardiogram, both were
I
like
think
a
the
double
right's
barrel.
looking okay. Yeah.
I think it will
I
be
think
fine,
they're
Shaq.
both pretty good. Yeah. The left could come back a couple of millimeters, but otherwise, yeah. That's what I would do, but otherwise I think you're pretty much ready.
Go again to go to RAO just to clearly see.
John Franco wants you to go RAO if you can hear him.
Yeah. I'll go RAO, but
Just to profile the right.
Yeah, left has come.
just one check here, and then I'll go to RAO. Come to RAO.
Yeah.
Huh?
I think
Can you hold it here? I will.
that's looking good.
RAO is not helping Gianfranco. Okay, go more cranial.
No.
More cranial. Lot of cranial. Okay. Let's try. Because of the crossing of the pulmonary artery, the whole thing is getting distorted.
Yeah.
See, here it looks like I'm not in the proper position on the right, but which was the view that showed right better?
That's completely confusing, isn't it?
Yeah. But I have not moved much, so show the previous.
Yeah. So that's a useless suggestion from Gianfranco because it confuses everything.
Next. No, previous.
Being confused, then wrong.
Previous. I think this is the view that probably, I think this if I have these two like this, then I think it's fine. Show the previous.
Yeah.
Previous. Yeah, this was better for the right, I think.
Yeah, these are the two views, the caudal and the lateral.
Can you just go to this caudal once again?
Oh. And I'll stick with the lateral.
Lateral we have not done
If
so
you
far.
are, I think I would stick with the lateral if you've only got one plane to work with.
Shaq, I think in this view I will have some degree of overlap. Get back to that same first view, that LAO 45. Let me see whether. LA of 45.
I think we're beginning to make it more complex.
Now I'm going to deploy Shaq. This is the last picture.
Dynamics. I'd be keen to get one. Yeah. Yeah. So just check on this in case you've pulled anything.
Yeah, I'm coming there. I'm also injecting more and more in a small child. I think I'm okay here, Shaq.
Yeah, exactly.
Okay.
Yeah.
So
don't you think this is
I
a
am
good
taking
view
care of
to work
right
on?
and you are getting in the left. Is this contrast enough? Okay. Okay, fine. Yeah, start inflating. Yeah. Go in. Go in, go in. Okay. So both stop at 10. Stop at 10. Mine is also 10. 12. Okay. Actually, the hemodynamics are stable because of the PFO. I'll try to get an RV pressure now.
Myself were commenting that if you use an indeflator, you lose basically one set of hands. And I think both Mark and myself would inflate with one hand and control the catheter, either push or pull with the other. And then you can always re-inflate fully with an indeflator after.
Yeah. Actually, Dr. Oliver,
Okay, so
I have
now
on my
there
right
should be better
hand Uma
hemodynamics.
Mageshwar, one of the RV pressure.
Scale.
What we'll do is we'll go to 12, 12 on each now once, and then we will. The balloon also maybe partially be occluding. I'll take out the balloon after I go to 12. Sister, just see whether both of us are 12, going to 12.
One question before you go to 12.
Yeah.
One question before you go to 12. What's your bailout if one of these guys going to burst?
I have a barred 12. Mine is 12. Okay, deflate. I have a barred live stream covered stent, SOS. Is that your question, Mark?
No, Gregor.
Gregor, okay.
Is that your question about
you answer. Thank you. Thank you very much. And congratulations. I like your result.
Let me first get the balloon out, then I will get better pressures. Out. Okay.
This is a fascinating, challenging case, isn't it? And everybody in the audience here, full room, really glued to the screen.
Yeah, I would have actually loved to come and sit there and watch.
We can do a hologram if you'd sent your pictures.
Actually, watching is more fun, Shaq, rather than doing.
Oh, absolutely. You're telling me.
Okay. See, the pressure.
But equally, watching can be painful.
Yeah, I suppose I'm not making it painful. Okay, Shaq, this is the hemodynamics. It's not. It's still 80.
Yeah. Yeah, but that's better than suprasystemic.
Yeah, but
and you've probably still got the balloon inside the sheath, haven't you, or have you come out?
No. Sheath is inside. I can go with larger, but in fact, Dr. Mark was warning me.
No, balloon.
See, I have gone to a 12, to 10. Maybe I can go to a 12.
Why don't you do an angiogram first?
Yeah. It just got flushed. Can you freeze it?
Another projection, caudal one?
Yeah, I'll do that. Freeze this. Just go back. Back. Enough.
On that view, it looks good.
What view? Maybe come to caudal. But I'm surprised why there should be still an elevation, because the 2 to 3 millimeter PA has become 10 millimeter PA. I was anticipating a little better fall in the RV pressure.
Well, I wasn't. And you've got a little distal stenosis probably, or twist.
Shall I put in
In
two
the right.
12s and dilate both? 12 into 2 do you have? Mustang? 12 into
I think, personally, let me go through, let me go through the panel, because I think I know what I would do. So let's start with Gianfranco. Very
Yeah.
quick brief, because
I should be happy with that result.
you should be happy. Next, Gregor,
Happy, congratulations.
Mark. Stop there. And Oliver.
I probably would
Bit
take
nearer, bit nearer.
I probably would take the pressure in the distal branches on both. If there's no pullback, I think that looks excellent.
I would be
5
more
RC
than
again.
happy with that hemodynamic and angiographic result, thinking or knowing that you haven't ruptured anything, you've got good pressures, and so I would be happy with all that. I wouldn't do any more at this stage.
But the
Other than
the
pressures.
RV pressure is 80, Shaq.
Any suggestions? Yeah, I know, but do you want to
Why not?
over-perfuse the lungs and get into a bit more problems?
But anyway, the systemic pressure is 140, so it's
Cut down the FiO2.
55%
Yeah.
Shaq, Shaq, one good thing that has happened is the saturation from 80% has become 100% now, as expected.
Yeah.
Now you are cutting down the FiO2.
So do you want to make them worse by reperfusion? Do you want to make them worse by reperfusion and just going for even better?
No, I'll
with
go
what
by
you've got?
Oliver's
I would be really
suggestion.
happy with.
I will go for a pressure gradient across the.
Yeah, I'm going to transport. I'm going to stop you there and transport you over to Frankfurt to stop you doing any more.
Sure. Close.
Yeah. No, I think, Shiva, if you do the pressures, but we'll stop and leave you with this. That's a brilliant result.
Yeah.
A challenging case. So congratulations to all
Shaq,
your team.
Shaq, actually, Shaq, are you still with me?
Yeah, we are.
Yeah. There is one
we
very
were.
small baby with a severe conduit stenosis, which is also ready in the other lab. Whenever you are ready, I will come back.
Oh, gee whiz. Okay, we'll come back later.
Okay. Thank you.
All right. Thank you.